When a city first learns to mark its losses with ink and paper, something subtle and irreversible begins to happen. A bell tolls, a clerk bends over a table, a name or a shorthand for a cause is set beside a column. The act is at once humble and an act of power, the transformation of flesh and story into a line on a sheet. Long before there were laboratories and microscopes that could peer into the invisible, rulers and communities had learned that counting people, and the events that punctuate their lives, helped them to order armies, collect taxes, settle inheritance, and, in time, to reckon with illness itself. This tale begins with those earliest habits of counting, lists made for politics and for memory, which would slowly become the basis for a new kind of public knowledge. The practice of enumerating people is ancient and often practical. In classical antiquity, when Roman magistrates summoned the heads of households to give account, the purpose was not curiosity but civic order, to determine who owed duty, who could be called to war, who could vote. The census of the Roman world was instrument and ritual at once, performed at regular intervals so that the state might measure itself against the lives of its citizens. This procedure, its cadence, its vocabulary, and its penalties for false reporting, taught a lesson that would echo across centuries. The state can only act on what it first learns to name and number. Far to the east, different administrative logics produced other forms of enumeration. In imperial China, household registers, tax lists, and periodic tallies were used to allocate grain, conscript labor, and control movement. When dynasties rose and fell, when borders shifted and capitals moved, these registers were adapted and reused. They became instruments of an extended bureaucracy that watched over both resources and people. In one recorded return under the Ming household surveys, whole provinces were carved into counts that astonished later historians for their scale and for the intimate bureaucratic intimacy they implied between ruler and ruled. These were not, initially, instruments of health, they were instruments of governance. Yet the pattern is the same. Where there is a list, there will be, sooner or later, a curiosity about what the list can explain. Between these distant precedents and the modern idea of public health, there lay a different, distinct development, a slow westward convergence of parish clerks, plague fear, and the printed sheet. In early modern London, the weekly bills were not scientific forms but a local answer to a terrifying practical problem. People were dying in numbers that made normal life ungraspable. The weekly mortality sheets told which parishes had buried how many bodies, and sometimes even the cause of death. They were produced at the behest of civic institutions and carried in the hands of citizens like news. The information was raw and uneven, often collected by elderly women known as searchers who determined cause by inspection, and yet it made visible what had previously been only rumor and rumor's shadow. Those scraps of paper, produced and read in the public squares and private parlors, became a mirror on the city's health. If the bills of mortality are where the habit begins, then the habit's transformation into a systematic inquiry can be pinned to a modest but astonished observer. A draper by trade who rose to a kind of amateur authority, John Graunt opened the bills to the light of calculation and pattern. In the year 1662, he presented to learned men a compilation that read the city back to itself, not only as a litany of deaths, but as a structure of rates, ratios, and recurrent features. Where the paper had been a catalog, his analysis made it an argument that population could be estimated, that sex ratios and infant mortality could be inferred, that some causes of death were misclassified, and that the fickleness of plague and the steadiness of other causes implied different kinds of public response. His text, published under a title that sounded at once practical and grave, proposed that the city could be known through its numbers. That claim was radical. It implied that policy might be guided by observation and arithmetic rather than by supposition or sermon. The immediate consequence was not a law or an institution. It was the admission, into the parlors of the learned and the registers of government, of a new language for talking about life and loss. Imagine a scene drawn with the texture of ink and breath, a narrow London room, A single mullioned window, the light slanting on a stack of printed sheets. A man who sells cloth by day arranges these slips, tabulates columns with the patient hand of a tradesman, and reads back an unexpected fact. Certain causes, the consumption, the rupture of the mother, names that then sounded blunt and particular, recur in patterns. He also notices what the sheets obscure: the invisible cohorts who die beyond the parish, the children whose burials are lumped into crude categories, the poor whose names never make it to print. The discovery, then, is double. Data can reveal and data can deceive. The craft of early demography was as much about pointing out the blind spots of counting as about offering new certainties. That double lesson, that numbers both reveal and elide, became a recurring motif in the centuries to come. Each new effort at measurement exposed something previously invisible, and at the same time created new questions. If the bills suggested a rising tide of certain complaints, who and what was responsible? If there were sudden spikes, were they real epidemics or changes in the way causes were recorded? The act of counting created, in other words, puzzles that invited further counting and better scrutiny. The human consequences of those puzzles were immediate. In a parish where burials rose, the grief of families was recorded not only as sorrow, but as an argument about social condition. Townsmen kept lists not merely to know how many had died, but to decide whether to close a market, to isolate a street, to limit burial rites. Listing became a form of civic conversation about risk and responsibility. It introduced to public life an uncomfortable question: what number of deaths makes a city sick, and who has the right to declare it so? This is also the point at which technical modesty matters. The bills were fragile instruments. Their collectors varied in competence and motive. The reach of the sheet was limited by geography and by the politics of parish boundaries. Yet the very limitations made the subsequent debates richer. Where records were faulty, critics sharpened their questions. Where officials wanted authority, they sought to standardize. The movement from scribal irregularity to systematic registration is not a story of linear progress, but of contest, between those who wished to use numbers to govern and those who feared that counting was a pretext for control. In the shadow of the Great Plague and the Great Fires, the city's appetite for knowledge hardened. When armies need mustered or quotas met, the state returns again to the convenience of lists. But now the lists were not only for soldiers and taxes, they were a provisional optic on the health of populations. The methodological innovations of the 17th century, the careful tabulation, the attention to rates rather than raw counts, the critique of bias in the sources, would be taken up, century by century, by reformers and administrators who wanted to know what to do about poorhouses, workhouses, and later, about municipal sanitation. And yet a question remained like a shadow at the edge of every ledger. When a life is converted into an entry, who speaks for the life? The clerk records a name and a shorthand cause. The family remembers a whole biography. The list, by its nature, compresses. The historian's task, and the storyteller, is to pry open that compression without losing sight of what made the practice urgent in the first place. The human face at the top of the sheet, the funerals, the sudden empty chairs at a table. Measuring health was never only a technical achievement. It was, from the beginning, an ethical labor, to translate grief into evidence in a way that could do justice to both the individual and the collective. By the end of the 17th century, the modest acts of parish clerks and the sharper calculations of curious men had set in motion a widening institutional appetite. The counting that had once been a pragmatic response to crisis was becoming, slowly, a recognized resource for governance. Registers would multiply, questions would become more precise, and the language of rates and ratios would gain political teeth. What had started as lists to make sense of immediate calamity was, quietly and inexorably, transforming into a grammar for modern public life. A grammar that would enable new policies, new responsibilities, and new anxieties about surveillance and the boundaries of civic knowledge. What follows in the story is the tale of how those lists, once constrained to a parish or a palace, were gathered into larger instruments, actuarial tables and insurance ledgers, maps that plotted cases on streets, and eventually, the registers of nation-states. Each innovation carried the old paradox forward. Counting improves capacity to act, and yet every act based on counting reshapes the very lives it purports to describe. In the next movement of our narrative, we will follow how the logic of reckoning risk, first with money and then with maps, turned private sorrow into public policy, and how ordinary people found themselves living inside the very numbers that were meant to protect them. There is a sound that accompanies the counting of lives that is neither the scratch of a pen nor the hush of a ledger room. It is the hush that falls when money and mortality meet. In the quiet offices and coffee houses of early modern cities, men and women who traded not in bodies, but in promises discovered that life could be converted, with alarming immediacy, into a financial question. Who would pay when a laborer fell sick? Who would bury a child who died before its name was fully spoken? The arrival of life assurance and the nascent art of calculating probabilities did not simply invent markets. It invented a new grammar for speaking about bodily risk, responsibility, and the obligations of communities and states. The first formal step from counting to pricing arrived with a subtle mathematical triumph. In the year 1693, an Englishman, better known among his friends as an astronomer and forerunner of modern scientific method, compiled a table from the birth and death registers of a Silesian town. He did not set out to cure disease. He set out to understand how long, on average, people of given ages might live. The table allowed one to estimate how much a promised future payment, an annuity, ought to cost in the present. The implication was enormous. Life could be rendered into an actuarial calculation that could guide contracts and prices. From that quiet paper, the scaffolding for a new profession later called actuaries began to emerge. Not long after the Life Tables publication, the first organizations that bore the name and function of life insurers appeared. In the year 1706, a collective of subscribers created what they called an amicable society for perpetual assurance. Its method was simple and communal. Members paid small sums into a common fund, and when a member died, the fund provided for survivors. The idea was older in practice. Mutual aid among guilds and fraternities had long buffered families against sickness and burial costs, but the society made the practice explicit, pooled, and institutional. In the course of a few decades, these experiments multiplied, and in the year 1762, a new kind of company formed, one that based premiums on mathematical ideas about mortality and the age of the insured. That enterprise brought into public life the notion that fairness in premiums could be grounded not in tradition, but in data. To understand the human consequences of these transformations, imagine a small textile town at dawn. A widow, sleeves threadbare, goes to the register to claim a modest payment left by her husband. The clerk at the assurance office consults a book more precise than any parish ledger, an age table, rows and columns showing whether it is probable that a man of 40 will live 10 more years, whether a mother in her 30s will survive a particular illness. For the widow, this is not intellectual abstraction. It is bread. For the clerk, it is policy. For the mathematician who produced the table, it is both puzzle and triumph. The data that once described the rhythm of births and burials is now a tool for deciding who will be supported and under what conditions. The emergence of these markets brought both relief and new anxieties. On the one hand, mutual funds and insurance contracts reduced the immediate precarity of illness by pooling risk. They allowed households to plan in ways that were previously impossible. On the other hand, the logic of shared risk introduced questions that were as ethical as they were technical. If premiums were set by age and occupation, did that punish the poor before misfortune struck? If a fund excluded those deemed unhealthy, did it not leave exactly the vulnerable without support? These were not merely actuarial questions. they were social ones. They asked who deserved protection and on what terms, and whether the act of pricing life could be neutral toward existing inequalities. During the long 18th century, these debates intensified. The application of the life table to commercial contracts required assumptions about the stability of populations, about the fidelity of parish registers, about the continuity of war and peace, that were easily upset by real events. A sudden epidemic, a migration wave, a war's casualties would reveal the fragility of models built on past patterns. Yet the appetite for precision grew. Mathematicians and reformers argued that fair premiums depended on better data, on larger samples, on a willingness to convert mortality into numbers that could travel across offices and nations. The work of transforming anecdote into aggregate required institutional support, standardized registers, uniform definitions of cause, and above all, an ethos that trusted calculation as a kind of civic virtue. If companies and actuaries forged one path, another, more grassroots route to risk management ran through the neighborhoods, factories, and docks, the friendly society. These voluntary associations were less interested in sophisticated probability than in mutual survival. For a small weekly contribution, a member received cash during sickness and help with funeral costs. The societies organized lodges, rights, and networks of reciprocal obligation. In many industrializing cities, the friendly society was the principal shield against the economic shock of illness, and their moral language emphasized mutual duty rather than actuarial fairness. Yet even here, actuarial thinking began to creep in. Societies found that their funds could be drained by disproportionate claims unless they devised simple rules, exclusions for pre-existing conditions, waiting periods, contributions that reflected the realities of age and work. The grassroots practices of mutual aid and the high-minded math of actuarial tables were different responses to a shared problem: how to make unpredictable human fragility legible and fundable. The encounter between private insurance, mutual aid, and statecraft eventually rendered the problem political. Industrial societies produced concentrated urban populations whose patterns of illness mattered for productivity, stability, and legitimacy. Employers and governments began to ask, could social stability be purchased through public schemes? The answer, in some countries, was to move from voluntary pools towards statutory arrangements. In the decade that began in the year 1883, a dramatic experiment was launched under the authority of a chancellor of a newly unified empire. The laws he sponsored created compulsory insurance for industrial workers, mandated employer contributions, and thereby enshrined the principle that the cost of sickness could be shared at the level of the polity. The move altered the moral ecology of risk. Protection was no longer merely a private arrangement or a matter of local reciprocity. It became part of the architecture of modern governance. This transition carried theatrical and practical consequences. Insurance underwriters and state functionaries both began to demand better registers and more consistent definitions of illness. The state had reasons beyond compassion to care about mortality tables. A healthier workforce attenuated social unrest, reduced the fiscal shock of epidemics, and facilitated conscription when needed. The insurer, whether private or public, had reasons that overlapped with those of the civic reformer. Predictable costs required predictable patterns of disease and death. Thus the appetite for standardized vital registration and for the professionalization of those who collected and interpreted the numbers intensified. Registers that had once been parish artifacts became instruments for national calculation. Yet these instruments reshaped the people they purported to describe. When employers required medical certificates to justify sickness pay, when friendly societies policed claims, when offices set premiums by occupation, the intimate facts of illness became subject to surveillance and validation. Workers learned to perform health in ways legible to bureaucratic eyes, to seek a certificate, to comply with a visiting physician, to justify absence. What had begun as mutual aid became a system of documents and attestations that reorganized personal relations. The ledger did not simply record life, it disciplined it. Ethical tensions multiplied. The same register that allowed a widow a modest pension could be used to exclude communities deemed too risky. Age-based premiums had the virtue of spreading cost fairly by actuarial logic, but they also formalized age as a marker of diminished entitlement. Employers sometimes resisted state-mandated contributions, seeing them as an invasion into the autonomy of enterprise. Critics feared a new form of dependency. Advocates argued for social solidarity. The vocabulary shifted from charity to rights, and along with the semantic shift came institutional change. Another consequence was the professionalization of those who interpreted the data. The actuarial specialist, the person trained in the mathematics of life contingencies and survival probabilities, became a new kind of expert. His work was not merely calculation, it was judgment cast in the language of probability. The expert's opinion carried the weight of legitimacy. Insurers, regulators, and the courts deferred to it. Yet that deference was not uncontested. Workers' representatives and social critics insisted that numbers, however precise, could mask the contingency of disease and the structural sources of ill health. The tension between expert calculation and popular experience became one of the defining frictions of the age. Across this terrain of ledgers and lodges, one idea persisted, that converting health into quantifiable risk made intervention possible. If mortality could be forecast, premiums adjusted, and funds pooled, then poverty due to illness could, in principle, be prevented. That promise animated reformers and underwriters alike. It also contained a caution. Actuarial models are only as humane as the social choices that frame them. A table can recommend reducing payouts to balance a fund. A polity must decide whether balancing a fund is a sufficient moral aim. Toward the close of the 19th century and into the years that followed, these debates became part of larger contests over the role of the state, the rights of labor, and the responsibilities of capital. Insurance had matured from parish charity and mercantile experiment into a mechanism that could be shaped by law, influenced by science, and contested in parliaments. The arrival of compulsory and social insurance in several industrial states remapped duties. Sickness was no longer merely a private misfortune, but a social fact to be managed through collective means. As we move from the experiment of premiums and mutual aid toward the next stage of our story, a new question emerges and demands an answer. When risk is known and priced, does that knowledge change the pathways of disease itself? The actuarial imagination turned uncertainty into price, but others turned the same question into a map. If insurers and states wanted safer populations, they needed not only to pool risk but to reduce it at its source. That intellectual nudge, from pricing the future to preventing the present, is the hinge upon which the story swings toward the science that would plot disease on streets and neighborhoods rather than merely on balance sheets. When the market of actuarial tables and mutual funds looked up from its ledgers and asked how to make populations safer rather than merely to price their misfortunes, another kind of work was already beginning in streets, wards, and offices. The work of tracing patterns where none had yet been seen. This was not a single discovery so much as a change in habit, a willingness to follow disease like a shadow, to ask not only who had died but where they lived, where they drank, what they ate, with whom they slept. The new inquiry treated illness as a phenomenon that happened in place as much as to bodies. It demanded maps, lists, interviews, and patience. It would be called epidemiology. The problem that provoked this transformation often presented itself as a mystery. A neighborhood would fill with noise and grief. Houses would empty. The parish clerk's column of burials would thicken as if with a secret language. People wanted to know why entire streets seemed to fall ill while neighboring lanes did not. The answers could not be found solely in theories of miasma, that disease rode on foul air, nor solely in metaphors of contagion. They required a different instrument. The map as evidence, the interview as experiment, the clustered case as clue. One of the most famous acts in this new repertory took place in a Soho alley on a late summer morning. On the 8th of September in the year 1854, a physician with a notebook and a dogged patience began to pin cases on a sheet of paper. He marked ghostly dots where people had become sick and then died, and those dots arranged themselves not at random, but like hailstones around one common point, a public water pump. By tracing the geography of suffering, he argued that the pump had been drawing poisoned water. He persuaded local authorities to remove the pump handle. The flow of new cases dwindled thereafter. The scene of inked marks turning rumor into location, of questions moving from air to water, is often remembered as the birth of a modern habit, finding the cause by mapping the effect. But the map alone did not create certainty. The victory was as much rhetorical as empirical. The clustered cases, the testimony of neighbors, and the comparison of water sources provided a narrative that could be told to people in power, a story that turned scatter into pattern. The method was simple yet rigorous. Gather who was sick, where they lived, and what bound them together, then look for a common thread. That practice, repeated in city after town after ward, transformed public health from a matter of isolated compassion into a discipline capable of guiding policy. Behind the map stood a different machinery of knowledge, the office that collected deaths, the registrar who insisted on categories, the analyst who compared regions. In England, the system of civil registration and the officials who compiled the national returns supplied the raw stuff of those maps. The statisticians who worked within those offices began to sort causes of death, to compare districts, to notice correlations between the density of population, the altitude of neighborhoods, and the burden of certain illnesses. These observations were not neutral facts. They were arguments about the social order, about overcrowding, sanitation, and the conditions that made entire classes vulnerable. The office and the map together acted like a microscope focused not on cells but on societies. Inside hospital wards, parallel discoveries were being made by a different set of observers. In the obstetrical clinics of a great imperial capital, a young physician noticed that one ward's mothers died in numbers that seemed obscene compared with another's. He sought reasons in ritual and in professional pride, in instruments and in education, until he saw the pattern in a new way, that those who carried the knife from the dissecting room to the bedside could carry something invisible with them. He ordered a simple, almost embarrassing remedy, the washing of hands in a chlorine solution, and the maternal deaths fell dramatically. His evidence was not a curve on a chart, but the ordinary arithmetic of reduced bodies dying, a direct argument that behavior in the clinic changed outcomes. Yet his peers resisted. The idea that the physician might be an agent of harm was hard for contemporaries to accept. The discovery, and the refusal to admit it, revealed that the science of patterns could threaten professional identity. These episodes, the pump, the ward, the office, exemplify the twin character of early epidemiology. It was both empirical and social. It required the technical tools of tables and maps, but it also required new social relations, trust between investigator and community, the willingness of officials to collect accurate data, and the courage of practitioners to act on uncomfortable findings. Where any element failed, so did the investigation. Where they all lined up, a fragile kind of authority emerged. Knowledge that could persuade administrators to close a pump, to alter a hospital routine, to invest in sewers. A crucial advance in this formation was not only the gathering of data, but its presentation. A statistic can be inert until it is given shape. A sequence of numbers becomes an argument when it becomes a diagram that a minister or a landlord can see and understand. The nurse who tended the wounded in a distant peninsula transformed mortality into a graphic that looked, at first glance, like a flower. Her diagrams, drawn with a clarity meant to move even those unfamiliar with arithmetic, compared avoidable deaths with those that accompanied unavoidable battle wounds. The diagrams made a moral point visible. Many deaths on the hospital floor were not the inevitable toll of conflict, but the consequence of neglect and poor sanitation. The image became a weapon in the struggle to upgrade care. Yet there were darker roots to the methods and institutions that produced these revelations. The appetite for surveillance and for systematic observation did not arise in a political vacuum. In empires and colonies, officials who recorded sickness and death were often less interested in humanitarian enlightenment than in protecting military strength, trade profits, and administrative control. The same techniques that helped to save lives in a metropolitan ward were used elsewhere to monitor enslaved laborers, to track migrants, and to secure borders. Some of the earliest forms of systematic disease observation accompanied the commerce and cruelty of the transatlantic traffic in human beings. The knowledge gained in these contexts was seldom neutral, and its benefits were unequally distributed. Any account of epidemiology's rise must therefore carry the question of power. Whose lives were counted, and to whose ends was the counting applied? This ethical shadow sharpened certain methodological demands. If data could be used for control, then standards of collection and interpretation mattered more than ever. Investigators began to debate not only whether a pump caused cholera or physicians spread fever, but how to avoid bias, to define cases carefully, to record exposure consistently, to compare like with like. The forms on which registrars wrote causes of death were rewritten. Manuals were issued to encourage uniformity. These were small, technical acts, but they were also political ones. A shared code of description enabled data to travel from parish to parliament, from colony to metropolis, and to acquire the capacity to justify large interventions. Even as the habit of mapping spread, its practitioners learned humility. Clusters persuade but can mislead. A plotted map might show a concentration near a market, and yet the real cause might be a laundry upstream or a social custom that drew people together. The investigator's task was thus a perpetual negotiation between the visible pattern and the invisible mechanism. Questions remained. How much could maps tell us about causation, and how much did they merely point to direction for further inquiry? The answer, which would become foundational to epidemiological reasoning, was that mapping was rarely conclusive on its own. It was most powerful when linked to coherent narratives of exposure, plausible mechanisms, and corroborating evidence from laboratories, interviews, and historical comparison. As the 19th century wore on, the discipline matured into a network of offices, journals, and societies where practitioners compared methods, criticized each other's assumptions, and refined the craft. Outbreaks were no longer merely local tragedies. They became occasions for methodological innovation. The logic of clusters and the practice of systematic registration together made possible the preventive aim that had only been whispered in the actuarial offices, to reduce the incidence of disease by changing the conditions that produced it. By the time maps, registries, and antiseptic practice had insinuated themselves into the machinery of public life, a new question had begun to define the field. Could the knowledge gathered at one place be generalized safely to another, and on what ethical basis should it be applied? The careful investigator would answer that question not with dogma, but with evidence, comparison, and an attention to context. The story of epidemiology's birth, then, is not a tale of triumphant technique alone. It is the story of a method learning to see its own limits and to place its discoveries within broader debates about power, responsibility, and human dignity. Thus, the map becomes, in our narrative, a mirror and a mandate. It reflects what societies have failed to notice, and it compels a choice about what to do next. The following movement of our story will follow how these choices, made in hospitals, in state chambers, and on the floors of colonial administrations, forged institutions of surveillance and prevention, some humane, some coercive, and all consequential. The quiet transformation that began with parish bills and actuarial tables soon reached a moment of structural consequence when governments, still uncertain how best to govern health, discovered that routine registration of life's pivotal events could serve as the backbone for both social order and public welfare. The registers that once documented births and burials only when someone cared to turn up and report them gradually became continuous, compulsory, and foundational records in the machinery of states. This was not simply a technical development. It was a profound shift in how societies understood the human lifespan and how they wielded that understanding in service of governance, planning, and power. Long before the notion of a state that managed public health had crystallized, many societies had already enacted legal requirements to record marriages, inheritances, land transfers, and other civil matters. But as modern bureaucratic states took shape between the 18th and 19th centuries, the imperative to systematize vital events, births, deaths, and, increasingly, the causes of death, took on a new urgency. A register that once served as a certificate for inheritance now also became a foundational input for population statistics, and by extension, public policy. This evolution marked the rise of an entire administrative apparatus, the civil registration and vital statistics system. In 1739, the King of France issued an edict requiring the clergy to keep records of baptisms and burials. These registers, originally kept to satisfy doctrinal concerns about salvation and church membership, were repurposed by civic officials as a source of demographic data. In Sweden, beginning in 1631, an early form of national register was maintained by the state through church parishes, long before the modern state conceived comprehensive civil registration. These registers laid a foundation for later systems in which secular authorities took responsibility for the continuous recording of every person's most intimate life events. Imagine a scene in a provincial town in late autumn, the leaves crisp underfoot, the parish clerk's quill gliding over parchment in a small, drafty office, while outside, a newly arrived registrar for the county steps into the beaten dirt street with a bundle of forms. The arrangement of those forms and the compulsion to submit them marked a new relationship between citizen and state. Personal events were not merely private facts to be whispered at the kitchen table. They became entries on public documents, legible to bureaucratic eyes, and by extension, inputs into national knowledge about population dynamics. The clerk's room, once an appendage of ecclesiastical authority, was now part of a larger, increasingly secular infrastructure of government. The logic behind civil registration was deceptively simple. By recording every birth and death, and by attributing causes of death with some consistency, officials could produce vital statistics, the rates of births, rates of deaths, and the distribution of causes within a population. These statistics, continuous and universal rather than ad hoc and local, could be used to compare regions, monitor change over time, and in principle, direct resources where they were most needed. Modern public health, in turn, could only function with such data, because without registration, it is impossible to measure improvements or deteriorations in community health, or to allocate scarce resources with any legitimacy. By the middle of the 19th century, bureaucratic offices dedicated to civil registration and vital statistics began appearing throughout Europe and the Americas. These were not modest county-level functions. They were elevated into recognized institutions within ministries of the interior or national statistical offices. They demanded staff, standardized definitions, and legal authority to compel registration. And with that authority came new tensions and responsibilities. For many people, the requirement to report a birth or a death was an intrusion into privacy. For administrators, it was a tool for governance. For historians today, those same registers provide a rich seam of evidence about the lived experience of past populations. Consider the infancy of such a system in a newly industrializing city. Steam rose from factories at dawn, workers crowded into tenements, and officials in a municipal registry office pored over returns for the week, comparing them with the city's earlier civil returns. Why, an alderman might ask, are deaths among infants rising in the northern wards while the southern districts remain stable? A clerk would consult cause of death categories, perhaps recorded with varying degrees of precision, and the officials would debate the meaning: overcrowding, contaminated wells, or seasonal influenza. The register, a dry ledger on its face, had become a stage for political argument about sanitation, living conditions, and social reform. And yet the growth of this bureaucratic edifice was not a steady march toward perfect knowledge. The registers were only as good as the procedures and motivations behind them. Early systems suffered from irregular compliance. Rural communities might neglect to report vital events, or a village under strain might delay reporting births and deaths because doing so carried tax obligations. Paradoxically, efforts to make registration universal sometimes collided with local traditions and suspicions of distant officials. Overcoming these challenges required not only laws but incentives, education, and a sense that registration served a public good that was not always immediately felt by individuals. Often, reformers and statisticians conducted campaigns to encourage participation. Broadsheets, town meetings, and legal edicts implored citizens to report deaths promptly and to be candid about circumstances. These campaigns bore a civic rhetoric. Registration was a duty to the community as much as to the state. The language of obligation was deliberate. Without near-complete coverage of births and deaths, the statistics produced could be misleading, and misguided statistics could, in turn, lead to misallocated resources or failed policies. Today's international guidelines on civil registration emphasize the importance of completeness and timeliness precisely because gaps in registration distort our most basic understanding of population dynamics. Cause of death categories, once a chaotic mix of local terminology and folk diagnoses, gradually standardized by the late 19th century. Physicians and registrars argued over definitions and classifications, because without a common language, the registers could not be compared across regions or nations. This struggle was not merely semantic. It reflected deeper debates about what counts as legitimate evidence. Who, for example, could assign a cause of death? A country doctor in his parish, an urban hospital physician, or a trained coroner accountable to a central registry? Answers to these questions affected not only the quality of the data, but the shape of the emerging bureaucracy, the offices, hierarchies, and professional roles that would steward public health data for decades to come. The institutionalization of registration and vital statistics also produced a way of seeing populations that previously had no official visibility. Differences in life expectancy between districts, unexpectedly high infant mortality in certain neighborhoods, or the burden of particular diseases all became measurable attributes rather than vague impressions. City councils and national assemblies could argue with figures, and appeals for infrastructure investment, better sewers, more hospitals or clinics, or clean water projects, could be backed by evidence of disparities in mortality rates. Numbers, once feared or ignored, began to anchor civic agendas. Yet the expansion of registration systems also brought tensions between individual experience and statistical abstraction. For a widow standing in line at a registry office to report her husband's death, the process could feel like a bureaucratic ritual divorced from grief. The clerk's ticking of boxes and assigning of codes might seem insensitive to the complexity of personal loss. In the ledger, one death might be reduced to a code beside a name. In the household, that death meant a missing voice at suppers, schools left without fathers, and debts unfulfilled. The bureaucratic state needed the register. The family needed recognition and dignity. Balancing these needs, the state's hunger for data and the human story behind every entry became part of the administrative imagination. Over time, registers and the offices that maintained them became nodes in ever more complex networks of governance. Birth certificates became prerequisites for schooling, travel documents, and property rights. Death certificates triggered claims on pensions and estate settlements. Vital statistics fed into national planning for everything from labor policy to military conscription. The register was no longer simply a document of record. It was a technology of inclusion and exclusion, a filter through which states could recognize and manage their populations. By the early 20th century, these institutional structures were embedded in the administrative fabric of modern states. Ministries or departments had divisions devoted to registration, statistics, analysis, and publication. The shift reflected more than bureaucratic growth. It signified a new pact between governments and populations. Individuals would be counted, described, and categorized. In return, the state claimed legitimacy to use that knowledge in making decisions that affected the living and the dead alike. As this bureaucratic architecture matured, it enabled transformations of public health practice itself, allowing comparisons across regions, monitoring of disease patterns, and the identification of emerging threats. But it also raised new philosophical questions that would shape the next chapter of our narrative. When tiny ticks in ledgers determine how governments allocate resources or enact protections, who decides the categories, and whose stories are made visible or invisible through the act of registration. That inquiry lies at the heart of the next movement in our journey through the history of medical statistics and the state. In the early years of the 20th century, the world faced a catastrophe that would place death itself into the realm of political decision-making and elevate the humble act of counting into a matter of national survival and international politics. At a time when the First World War still rent the continents with armies and artillery, an unseen enemy moved as easily as the troops and the cargo ships that crossed seas. When the deadly strain of influenza that erupted in the spring of the year 1918 swept through military camps, trenches, and cities alike, it infected perhaps 1/3 of the global population and killed tens of millions of souls over a span of months that felt like a lifetime for those who lived through it. For governments, officials, and ordinary families alike, the question was not only how many were dying, but what the numbers meant for the polity and for war. In the haze of those months, the very process of counting, of quantifying sickness and death by age, locality, and occupation, became part of how states responded, sometimes well, often poorly. In some regions, authorities, eager to maintain morale and support for the war effort, suppressed or delayed the release of figures about the outbreak's severity. In others, local health boards grappled with daily counts that looked at once like columns in a ledger and like the yawning gap of absence at a family's supper table. The politics of numbers, which figures to publish, how to classify causes of death, and where and when to intervene, moved rapidly from technical detail to heated public debate. Picture an urban municipality in the autumn of 1918. City clerks hunched over stacks of weekly returns, doctors issuing diagnoses that then needed to be coded into central registers, and municipal officials confronting press inquiries about rising mortality rates by district. These were not sterile deliberations. They were conversations about legitimacy. Who believed the authorities when they said that mortality was falling, or when they argued that certain neighborhoods were especially hard hit? The answers shaped not just policy but politics. Critics charged that published data underreported deaths or masked inequalities in health outcomes. Defenders claimed that inflated numbers would provoke panic and undermine social order. Disease statistics were suddenly matters not just of health, but of public confidence and political calculus. One salient tension emerged between transparency and control. In a few cities, local officials insisted on prompt publication of case counts and death rates as a civic duty, an appeal to collective responsibility and collective action. In others, officials resisted releasing detailed figures, fearing that too much visibility would alarm the public, disrupt labor supply, or weaken military recruitment. Seen this way, statistics were not merely records of loss but instruments of governance. They helped determine whether markets stayed open, whether schools closed, whether citizens obeyed public orders or ignored them. The content and timing of numbers mattered as much as the numbers themselves. These debates foreshadowed political dynamics that would recur in later crises. The global influenza pandemic of 1918-19 was not the first great pestilence in history, nor would it be the last. Outbreaks of plague, smallpox, and later respiratory diseases had reshaped cities and societies before, but its political impact was distinct because it played out in an age of mass media, expanding statistical infrastructure and modern states that felt compelled to respond with both authority and, at times tenuous, accountability. In earlier centuries, authorities might have relied on parish books and ad hoc inquiries. Now, they had national statistics and public opinion as actors in the same arena. Governments confronted perplexing questions rooted in numbers. How many excess deaths above baseline really indicated a crisis? Were the observed differences between rural and urban mortality due to environmental conditions, reporting practices, or political distortions in the data? These questions were not mere academic quarrels. The answers informed decisions on quarantines, restrictions on public gatherings, and even the diversion of scarce medical personnel to high mortality districts. The struggle to interpret and communicate mortality statistics became, in effect, a battlefield of its own. The tensions around transparency also sparked ethical disputes about privacy, stigma, and the rights of citizens. In some localities, detailed reports of who was dying and where they lived created fear and social division. In others, citizens demanded fuller disclosure as a matter of democratic accountability. The mere act of naming a cause of death, categorizing it under labels that might carry social stigma, raised questions about the relationship between the state and its subjects in a time of crisis. These questions anticipated later debates in the century about surveillance, individual liberty, and public welfare. In the face of political contention over data, some health officials turned to novel institutional designs for monitoring the pandemic. They experimented with new forms of weekly case reporting, dashboards of municipal figures, and comparative charts that aimed to make sense of rising and falling trends in infection and mortality. Here, the legacy of earlier epidemiological practice, the mapping of cases, the systematic categorization of causes, intertwined with emerging technologies of communication, telegraphs, newspapers, and wire services that could transmit numbers across continents. The state began to see statistics not only as tools for internal management, but as signals to external audiences about competence, control, and legitimacy. These choices had consequences beyond public health offices. In some regions, political leaders used pandemic statistics to justify extraordinary measures, closures of ports and borders, mandates on public behavior, and reallocations of resources that in peacetime might have seemed impossible. In others, political actors seized on mortality figures to criticize incumbents, eroding trust in institutions already strained by war and social upheaval. What had been abstract debates about rates and ratios became raw material for political argument about leadership, blame, and responsibility. Another layer of complexity emerged when numbers traveled beyond national borders. States compared mortality rates with neighbors, not just to understand their own populations, but to shape narratives of competence or failure. The geography of statistical publication became a political arena. Countries that did not openly report data were sometimes accused of obfuscation. Those that published too much risked fueling fears of collapse. In the interplay of domestic politics and international reputation, the pandemic statistics became actors in diplomacy and national identity. As the influenza wave receded, and the war that had partly concealed and partly accelerated it drew to a close, the political memory of the pandemic, like the pandemic itself, was uneven. In some societies, the experience fostered stronger public institutions and a renewed faith in collective action. In others, the politics of counting became shorthand for distrust and division, and the statistical registers that had once promised clarity became symbols of contested authority. Scholars in later decades would debate why the pandemic left such divergent legacies in different regions, debates that turned back, again and again, to the fundamental question of how societies used numbers in moments of crisis. The politics of the pandemic, where numbers were made, hidden, argued over and weaponized, did more than shape emergency responses. It seeded deeper reflections about the character of modern governance, about the role of transparency, the capacity of institutions to build trust through evidence, and the fragility of that trust when societies are fractured. In the next phase of our story, we will examine how the practice of generating and interpreting statistics evolved further into systems that did not simply record crises, but anticipated and modeled them, giving rise to new forms of predictive knowledge in public health. There comes a moment in the life of any discipline when description, however faithful, is no longer enough. The question becomes not only what has happened, but what will happen, and what must be done to alter that future. The habit of mapping disease and compiling registers gave societies a vocabulary to explain past calamities. Prediction required a different courage. To place a model, a simplified, interpretable machine made of equations, assumptions, and data, between the present and the unknown. This is the story of how epidemiology learned to forecast, of how models moved from the margins of mathematical curiosity into the center of public decision-making, and of what that move revealed about the promises and limits of governing by numbers. The first sketches of predictive epidemiology arrived from surprising quarters. A physician who had spent part of his life with microscopes and field notes also had, in him, the temperament of a mathematician. Building on work in tropical disease and mosquito ecology, early 20th century investigators and their collaborators began to write down relationships that linked the number of infected people, the vectors that carried infection, and the environment in which they acted. These initial equations were meant to show how interventions, draining swamps, reducing mosquito breeding sites, could change a trajectory of disease. The effort made plain an important conceptual leap. Disease could be modeled as a dynamic process, one that unfolds in time according to explicit rules. Sir Ronald Ross's work on malaria, his calculations about transmission, and his subsequent mathematical reports around the years 1908 and 1910 are an early, seminal example of this turn toward predictive reasoning in public health. The mathematical language that would become familiar to generations of epidemiologists found a cleaner, more general form in the interwar period. In the year 1927, two mathematicians published a concise and elegant framework that resolved a host of empirical puzzles about epidemic waves into a small set of interacting compartments, those susceptible to infection, those currently infected, and those removed by recovery or immunity. Their contribution showed how a simple system of equations could explain why some infections flare and then die out, while others sweep through populations, and why interventions that change contact rates can, in principle, alter the peak and the size of an epidemic. These papers established the class of compartmental models whose logic still underlies much epidemiological forecasting today. The compartmental paradigm, usually summarized in shorthand by the initial letters of its categories, became a powerful didactic tool. It allowed an analyst to turn policy ideas into model levers, reduce the contact rate and the epidemic curve flattens, speed recovery and fewer people are infectious, vaccinate susceptibles and the effective pool shrinks. Yet the simplicity that made these models tractable was both a strength and a danger. A set of ordinary differential equations can illuminate the skeleton of transmission, but it can also conceal crucial flesh. Heterogeneity of contact, spatial structure, age differences, and the messy realities of behavior. The task of later generations was to preserve intelligibility while adding those complications that matter. Two linked conceptual devices became indispensable in this work. The first was a scalar summary of transmissibility that epidemiologists pronounce as R0, the basic reproduction number, a single number that, in a naive formulation, expresses how many secondary infections one primary infection causes in a wholly susceptible population. The clarity of the concept made it a powerful talking point for public audiences and policymakers. When R0 is above 1, an outbreak tends to grow. When it falls below 1, the outbreak wanes. The calculus behind this apparently simple phrase is subtle, and its numerical estimate depends on both biological and social assumptions about contact patterns and infectiousness. The modern genealogy of this concept draws on decades of work by mathematical demographers and disease modelers, and it took shape only after a sequence of theoretical and empirical advances across the 20th century. The second device was the idea that randomness, chance events in small populations, superspreading incidents, or stochastic fade-outs matters. Deterministic compartmental models capture average behavior. Stochastic models capture the variability that can make two otherwise similar cities experience very different outcomes. Over the course of the 20th century, the toolkit expanded. Age-structured models, network models that encoded who meets whom, agent-based simulations that treat each individual as a computational actor, and metapopulation models that stitched local outbreaks into regional pictures. Each innovation made the models more realistic, but also more demanding of data and computation. All of this mathematical progress mattered little unless models were linked to data. Here the modern story converges with the history of registration and surveillance. Real-time case counts, hospital admissions, and serological surveys began to feed parameter estimates that shaped forecasts. The feedback was reciprocal. Models, by highlighting the sensitivity of outputs to certain inputs, showed surveillance where to focus. If a model's predictions hinged on the age profile of cases, for instance, it created an imperative to collect age-specific incidents. In other words, prediction and prevention began to co-evolve with the bureaucratic capacities of states to gather, clean, and transmit health data. The politics of that co-evolution became brutally visible in recent decades. When a novel respiratory pathogen emerged in the spring of 2020, a handful of modeling groups, working with limited and sometimes contradictory data, produced scenarios. One influential report argued that without stringent measures, tens or hundreds of thousands of deaths could occur in single countries, and that healthcare systems risked being overwhelmed. Policymakers, confronted with those projections, enacted unprecedented non-pharmaceutical interventions, school closures, travel restrictions, and stay-at-home directives. The modeling exercise was not merely academic, it was a lever for policy. The report's impact showed, in stark terms, the power of models to shape national responses at speed. The Imperial College analysis of mid-March 2020 crystallized this dynamic and remains a striking modern example of modeling's direct policy influence. That influence illuminated both virtues and perils. A well-constructed model can reveal plausible futures and thereby justify preventive action whose success is measured precisely by the model, preventing the worst outcome from occurring. This creates a paradox. Effective prevention can make a dire forecast appear to have been wrong, breeding skepticism among the public. Models are not crystal balls. They are conditional arguments about futures that depend on assumptions and on human behavior. The public debate during the early years of the pandemic made this painfully plain. Different models, using different assumptions about contact patterns, latency, or population susceptibility, produced divergent scenarios. To an exhausted public, divergence could look like disagreement and thus erode trust. Model uncertainty has both technical and moral dimensions. Technically, uncertainty arises from incomplete data, unknown biological parameters, and imperfect structural assumptions. Morally, uncertainty raises questions of precaution. How much weight should policymakers give to a worst-case scenario that rests on plausible but unproven assumptions? Should governments enact costly measures to avert a catastrophe that might not materialize, or should they wait for better evidence and risk being overtaken by events? Such questions are not resolved by mathematics alone. They are political judgments in which models provide one kind of input among many. A further ethical complexity is the way models can simplify populations into groups for whom policies are recommended. When a model recommends physical distancing, it implicitly assumes a set of capacities and resources that not all citizens share. The poor, the precarious worker, and those living in crowded housing face disproportionate burdens in implementing some interventions. Thus, modeling choices have distributive implications. The scientific claim this intervention will reduce transmission must be read alongside social facts. Who can comply, who will bear the costs, and who will be left vulnerable by policy trade-offs? The computational turn in the late 20th and early 21st centuries deepened both capacities and dilemmas. Greater computing power enabled large, stochastic agent-based models that could simulate millions of virtual individuals. Richer datasets, mobility traces, social networks, genomic sequences allowed calibrations that were previously impossible. Yet richer data also amplified privacy concerns and the surveillance potential of health information. Model builders had to think not only about equations but about governance. How will data be collected? Who will control it? And how will model outputs be communicated responsibly to avoid misinterpretation or politicization? History offers cautions. Models framed as objective truths have at times been used to justify coercive measures that were ill-suited to social contexts. Conversely, failure to heed plausible modeling warnings has produced preventable damage. The lesson is not that models are culpable or miraculous. It is that they are instruments whose social life matters. Their design choices, which compartments to include, how to model contact, which data streams to privilege, embed value judgments. Modelers therefore carry a responsibility to make assumptions explicit, to quantify uncertainty, and to communicate findings in ways that policymakers and the public can interrogate. Yet the capacity to forecast has also brought remarkable benefits. Models informed vaccine deployment strategies by identifying groups whose immunization would have outsized effects on transmission. They helped hospitals plan for surges, and they offered a language in which trade-offs could be debated transparently. During crises, the dialogue between model and surveillance often produced rapid improvements in both. Better testing informed better estimates of asymptomatic infection. Clearer age-specific incidents informed school policy. Genomic surveillance clarified the emergence of variants. Prediction became a learning loop. Models guided actions. Actions changed data. New data refined models. As this chapter of the story draws to a close, a central paradox persists. The very institutions that models aim to protect, health systems, civic life, and public trust, are also the conditions that make modeling possible. A state that can collect timely, representative data, operate laboratories, and transparently report findings enables better forecasting. At the same time, the act of forecasting shapes public expectations and political legitimacy. The numbers generated by models are therefore not neutral artifacts. They are performative. They enter the world and, by doing so, alter the behaviors that produced them. The next movement of our narrative will examine how the infrastructural need of models, those relentless demands for clean, timely, and comprehensive data, accelerated the development of national registries and electronic health systems. We will follow how the state and its instruments responded to that demand, how individuals came to live inside streams of digital records, and how identity and health became bound together in the registers of modern governance. When prediction demands better inputs, the state must build the machinery that supplies them. The mathematical curves sketched in the quiet rooms of modelers call for streams of tidy facts. Who was born where? Who fell ill when? Which neighborhoods lost children at a rate unlike any other? Those streams arrive only when people, sometimes reluctantly, make themselves visible to institutions that record, code, and archive the intimate facts of life. In one sense, the story of modern health governance is the story of those streams becoming rivers. Civil registration systems, unique personal identifiers, national registries, and electronic health records that carry data from the bedside to the policy table. But a river shapes the land it runs through. So too do registers reshape citizenship, privacy, and the very sense of what it means to belong to a nation. Imagine a winter morning in a provincial registry office. A tired midwife, her fingers still smelling of the soap she used in a birth, cues to notify the clerk of a new child's arrival. She fills in names, dates, and places on a form that will travel into a larger apparatus, a ledger at the municipal hall, a record in the National Archive, a datum in a table that, over years, will reveal trends invisible to single households. In some countries, that single act of registration quietly opens the child to schooling, to healthcare, to a legal identity that anchors civil life. In other places, the failure to register births consigns families to a shadow existence. A child who cannot prove a name may be denied a place in school, a passport, or even the right to work. International agencies have repeatedly pointed out that birth registration is the hinge between private life and state recognition. Without it, exclusion and statelessness loom large. The architecture of registers varies widely, and some designs have proven extraordinarily generative. In the cold clarity of Scandinavian administration, a compact technical innovation made whole fields of research and governance possible. A lifetime personal identity number assigned to each resident and used consistently across hospitals, tax offices, and population registers. Where such an identifier exists and where health records, hospital discharges, and cause of death files can be linked longitudinally, scholars and officials can watch cohorts across decades, follow the consequences of exposures, and evaluate the long-term effects of policies. The Nordic experience has become synonymous with the virtues of near-complete population registers: continuity, linkage, and a capacity for follow-up that reduces selection bias and strengthens causal inference. These registers, in short, convert private histories into civic knowledge in ways that can improve care and inform policy. But these capabilities are not neutral. The Swedish personal identifier that empowers life course research also enables administrative reach. In a quiet paper, the technical possibilities of linking records were celebrated as scientific promise. Elsewhere, critics warned of the ethical trade-offs. What safeguards would keep sensitive records from misuse? And how could consent be managed when a whole nation's health becomes tractable as research data? The very feature that allows a demographer to follow the fortunes of a birth cohort also makes possible an employer or an insurer to make a judgment about that cohort's future. The registers that ease population science also demand a political conversation about boundaries, oversight, and the stewardship of data. Across the English Channel and in other national contexts, the press of administrative scale took a different institutional form. A national health service that treats people as entitlements introduced its own unique identifiers and, later, digital infrastructures for medical records. The identifier that helps clinicians find a patient's file, and that allows policymakers to compute hospital admission rates and monitor outcomes, is part practical necessity and part artifact of how care is organized. Electronic records promise continuity of care, speed of access, and a new kind of public health surveillance where anonymized aggregates and near real-time indicators guide responses. International assessments by policy bodies show that many countries have embraced electronic health records, but that fragmentation and lack of interoperability remain persistent obstacles to the smooth flow of data that modelers crave. The practical benefits of such systems are palpable in scenes that are at once ordinary and telling. Consider a hospital during a seasonal surge. A clinician, faced with a patient whose history was written across 3 separate paper files in different towns, now taps a screen and sees medication lists, allergies, and recent laboratory results. In an adjacent public health office, aggregated data from emergency departments feed dashboards that alert officials to an uptick in respiratory admissions in one district. Electronic records do not simply store past care, they become instruments of response. Epidemiologists can draw on hospital databases to estimate incidents, health managers can plan staff rotations, and researchers can design pragmatic studies that would have been logistically impossible in a pre-digital era. The promise is efficiency, and the promise is prevention. Yet the same circuits that deliver utility also carry risk. When registers are linked, sensitive attributes join the same chain: diagnoses, genetic markers, social circumstances. The state that can measure the incidence of a disease can also, if it chooses, single out neighborhoods, occupations, or ethnicities with extraordinary precision. The ethical stakes widen when private companies hold or process health data, or where identifiers used for welfare are lent to commercial purposes. Famous episodes remind us of the public unease that follows perceived overreach. In a small island nation whose population is genetically well characterized, commercial ambitions to assemble a national genetic database provoked protests and parliamentary scrutiny when corporate ties and political influence became entangled with promises of scientific advance. The controversy forced a national conversation about consent, ownership, and the boundaries between research and commerce. Legal frameworks matter. In a geopolitical space where privacy protections have been strengthened by statute, states, hospitals, and researchers operate under a set of obligations that define what may be collected, how it must be secured, and what rights individuals retain over their data. The regulation that harmonized data protection across an entire regional bloc set strict standards for processing health information, requiring explicit legal bases for many uses and imposing duties on those who manage sensitive data. Where such rules are robust, the public conversation about registers tends to emphasize safeguards. Oversight and rights. Where rules are weak or uneven, anxieties about surveillance and misuse multiply. The tension becomes acute in contexts where identity systems designed for governance are linked, intentionally or accidentally, to health services. A large identification program launched in a populous country promised to streamline service delivery by giving every resident a single digital identity. Linking that identity to health services, to banking, or to welfare could, in theory, reduce fraud and speed access. In practice, however, observers pointed to privacy risks and the potential for exclusion. Errors, mismatches, or deliberate linkage of records can leave people suddenly unable to claim entitlements. In some cases, the scandal of faulty records, a person declared dead, a fraudulently altered phone number tied to credentials, exposed how brittle these systems can be and how deeply they affect real livelihoods. These episodes underline a grim fact. When identity and health data meet in a digital registry, bureaucratic mistakes are not just administrative inconveniences. They can be existential blows to the insured and the vulnerable. There is another axis of exclusion often overlooked in policy debates: the absence of registers. Millions of births go unrecorded each year. Displaced people, indigenous groups, and undocumented migrants frequently fall outside the circuits of civil registration. The social consequences are stark. Without a recognized legal identity, a child may be denied vaccination programs, women may struggle to access prenatal care, and entire communities can find themselves invisible to public health campaigns. International agencies stress that building comprehensive civil registration systems is not merely a technical objective but a human rights effort. Identity affirms entitlement, and registration is a first line of inclusion. The health of a nation is, in this sense, partly measured by who the nation recognizes as belonging. What then is the civic bargain implied by registers of health? On one reading, the promise is straightforward. Individuals accept a measure of legibility so that the state can plan, prevent, and deliver services more equitably. On another, the bargain is conditional and fraught. Legibility must be paired with rights, remedies, and democratic accountability. Registers can be instruments of care or of coercion. They can connect people to services or strand them when systems fail. The way forward requires not only better technology but institutional design that recognizes these trade-offs. Rigorous data governance, transparent oversight, meaningful consent processes where feasible and accessible remedies for those harmed by errors. Finally, the political character of registers is not fixed. Registers have been and will remain sites of contestation. Advocates for public health will press for comprehensive data to close gaps and to direct resources where need is greatest. Civil society groups will push back when systems risk normalizing surveillance or entrenching discrimination. Courts and legislatures will calibrate the balance, sometimes by expanding protections, sometimes by allowing limited access in defined emergencies. The history of registers is, in short, a civic negotiation, an ongoing argument about what a polity ought to know about its people and what obligations the polity owes in return. As our narrative approaches its final turn, the question resounds: when a nation learns itself through registers, when identity, illness, and death are transformed into data sets, what remains of the face behind the file? The answer depends on choices yet to be made. How societies legislate protection, how they design inclusion, and how they teach officials to see records as representations of human lives rather than merely rows in a spreadsheet. The next and concluding movement of our story will step back from the architecture of registers and models to ask the largest question of all. What ethical horizon should guide a politics that governs health by numbers? And how might compassion, justice, and dignity be encoded into the very systems that measure us? There is a peculiar hour in any chronicle of counting when the instruments become the interlocutors. Registers, charts, and models cease to be mere tools. They speak back to us in the idiom of policy, morality, and imagination. Our long story, from parish bills to actuarial tables, from maps to models, from ledgers to linked electronic records, arrives at this hour. The question that has followed us from the first scribbled list now demands an answer in full voice. What does it mean, in human terms, to govern health by numbers? The answer is neither simple nor singular. It is a conversation composed of technical claims, ethical choices, and civic temperaments, and it is lived most vividly in the small scenes where data meets a face. We can begin with a practical proposition that is also a political promise. Systematic registration and reliable vital statistics make possible the planning and protection of populations. When a state commits to documenting births, deaths, and causes with continuity and accuracy, it gains the capacity to detect crises, to allocate resources, and to evaluate whether policies actually improve lives. International agencies and public health authorities have enshrined civil registration as a foundational right and an essential platform for social inclusion. The act of registering a birth is not only a technical formality, but often the threshold through which a child gains access to schooling, healthcare, and legal recognition. That linkage between documentation and entitlement is a modern civic achievement, and it underwrites much of the rhetoric of public health improvement. Yet that same archival promise births a set of moral dilemmas. Registers concentrate intimate facts in files and databases. They convert private events into public inputs. The ethical questions that attend this conversion are not abstract. They concern consent, guardianship of data, the rights of communities, and the obligations of those who hold authority over records. Scholars and practitioners have argued for the incorporation of ethical principles directly into the design and deployment of digital health solutions, insisting that governance, privacy protections, and accountability cannot be afterthoughts in a system built to prevent harm. Designing registers well, therefore, means balancing the collective good of epidemiological insight against the individual rights of privacy and dignity. If the ledger both empowers and endangers, the deeper political frame that helps make sense of that tension has a familiar name in the humanities: biopolitics. From the moment states first sought to measure populations, the act of counting acquired a governmental logic. Statistics render populations governable by translating diffuse lives into categories and rates that can be compared, aggregated, and acted upon. Philosophers and historians have shown how the very concept of a population as an object of governance arises in part through statistical practices. The power to know a people becomes the power to regulate them. This is a two-edged legacy. It explains how states can deliver services at scale, and it explains how the same knowledge can be turned toward control, exclusion, or discrimination when wielded without ethical restraint. Such dilemmas are not merely theoretical. They take shape in concrete policy choices about who is counted and how. Consider the ethics of linkage. When personal identity numbers permit hospital records, immunization histories, and socioeconomic data to be joined across databases, researchers obtain an unparalleled view of life courses and exposures. That visibility allows designers to evaluate interventions with remarkable precision. It allows epidemiologists to follow cohorts for decades and to learn what policies work. Simultaneously, linkage widens the surface for misuse. Commercial interests may peddle insights that undermine individual autonomy. Bureaucracies may deploy insights that entrench disadvantage. The civic bargain thus requires both technical capability and public accountability. Systems that enable beneficial research while imposing legal and institutional limits on secondary uses and on breaches of confidentiality. Another tension has to do with visibility by omission. The moral imagination of registers is as much about absence as presence. Those who are not in the file, children born in remote hamlets, migrants without documentation, members of marginalized communities, remain invisible to the instruments designed to protect and to measure. Exclusion from registers is not an abstract statistical gap. It is a political wound that translates into lack of access to vaccines, education, and legal protection. International actors have argued that strengthening civil registration is therefore a human rights obligation. To recognize a person is to acknowledge their claim on public goods, but such recognition must be pursued with care, not coercion, and with mechanisms to redress errors and exclusions when they occur. The relation between numbers and trust forms a central motif in the contemporary chapter of this history. Scientific models and official statistics only shape behavior effectively if they are perceived as legitimate. During crises, model projections and reported rates can either mobilize collective action or fuel skepticism and division. Research on the communication of model uncertainty has highlighted a peculiar dynamic. When institutions present forecasts as certain, and the forecasted catastrophe does not occur, often because preventive measures worked, the public may interpret the outcome as evidence that the model was wrong rather than as proof of successful intervention. Conversely, opaque communication about assumptions and uncertainty can leave citizens feeling manipulated. The practical lesson is clear and uncomfortable. Transparent, candid communication about the limits and assumptions of forecasting is itself a public health imperative. This leads to a question that recalls the earliest dilemma of counting. What does it mean to do justice to the singular life within an aggregate? The register reduces grief to a code. The model reduces unpredictability to a distribution. Yet policy must answer to individuals. The story of the human equation insists that institutions treat data as representation rather than replacement. That implies a series of institutional practices, procedural safeguards for consent and review, clear avenues for redress when data harms occur, and participatory mechanisms that involve communities in shaping what is measured and why. It also implies humility. Statisticians, modelers, and policymakers should recognize that numbers are conditional claims, arguments to be scrutinized, not final moral verdicts. The historical record offers both hopeful exemplars and stark cautions. When datasets and models were used to reveal entrenched inequalities in living conditions, they empowered reformers to demand sanitation, housing improvements, and equitable access to care. When the same instruments were mobilized to police certain populations or to rationalize exclusionary policies, the results were oppression clothed in technocratic language. The historian's obligation is to hold both examples in view, to celebrate the ways counting has made it possible to save and to serve, and to remain vigilant about the ways counting can rationalize injustice when detached from rights and public engagement. If this is at once analytic and moral terrain, it is also procedural. The human equation can be inscribed into the routines of governance. Best practice demands legislation that sets limits and obligations, independent oversight that audits data uses and evaluates impacts, ethical review structures that examine registry-based research, technical standards that minimize re-identification risks, and public engagement that builds shared understanding. In practical terms, these are not merely bureaucratic niceties. They are the instruments by which a polity converts the capability to know into a capacity to act justly. International guidelines on ethics and registry governance emphasize that registries should be coupled with transparent governance and with means for communities to contest and correct errors. Finally, the story bends toward pedagogy. Modern publics must be taught, in civic terms, what statistics mean and what they do not mean. Numerical literacy is not a technical specialty reserved for experts. It is a public art that underwrites informed democratic choice. When citizens understand the conditionality of models, the significance of uncertainty, and the provenance of statistics, they are better equipped to judge policy, to demand accountability, and to participate in debates about trade-offs. Democracies that fail to cultivate that competence find themselves trapped between technocratic rule and populist skepticism. Education, then, is a civic technology as important as any register or algorithm. As we bring the narrative to its close, the final image I offer is ordinary and stubbornly human. Imagine a kitchen table at dusk. Someone traces a child's name in a birth certificate, a nurse closes a patient's electronic chart, a modeler prints a simulation, and a minister reads mortality tables. Each of those acts is a vote in the human equation. How will we weigh prevention against liberty, surveillance against privacy, prediction against humility? The answer will not be found in any single spreadsheet or model. It will be stitched together, imperfectly, through law, ethics, public conversation, and the ongoing practice of respecting the lives behind the numbers. Counting did not begin as a moral enterprise. It began as a pragmatic one. But the more intimately states and societies know their people, the more urgently counting becomes a moral activity. The registers, charts, and forecasts that mediate modern public life are instruments. Like any instrument, they can be used to heal or to harm. The proper task of our era is to encode into their design the obligations that define a humane polity. Consent where possible, protection where necessary, transparency as a rule, and recourse when errors wound. If we can do that, the human equation will not be a cold calculus but a civic promise. That numbers will be marshaled in service of dignity, justice, and collective flourishing.